Om Swastiastu. Good morning, doctor and friends. We are group B7. We're going to be presenting about lung abscess. Please enjoy.
Hello, my name is Mani with the last 3 digits, student number 249. So today I'm going to explain about the background of our literature review. Rheumatic fever is an autoimmune disease caused by group A streptococcus infection. Rheumatic fever is more common in developing countries like Indonesia. Until recently, ARF was an ongoing medical problem. The high prevalence of rheumatic fever occurs due to the lack of public knowledge, education level, socioeconomic status and density population, as well as the lack of adequate health services in people of developing countries, which if not handled properly can cause many clinical manifestations and lose their productive use. These are the literature review questions. What is the definition? What is the epidemiology? What are the risk factors? What is the pathogenesis? What are the key diagnostic features? What is the differential diagnosis? What is the management, treatment, control and prevention of rheumatic fever? And what is the prognosis of rheumatic fever? Then, to the purpose of this literature review consists of to understand the definition of rheumatic fever, to understand the epidemiology of rheumatic fever, to know the risk factors, to understand the pathogenesis, to know the diagnostic features of rheumatic fever, to understand the differential diagnosis, to understand the management, treatment, control and prevention of rheumatic fever, and to understand the prognosis of rheumatic fever. The benefits of this literature review are: this paper is useful for increasing knowledge and understanding as a medical student regarding rheumatic fever, including the definition, epidemiology, risk factors, pathogenesis, diagnostic features, differential diagnosis, management and prognosis of rheumatic fever. This knowledge can be used as a basis for medical students so that later on they can fully understand about rheumatic fever. Thank you very much, and my friends will continue the next part.
Hello everybody, my name is Hara Prabudinda Sakti with the student number of 253, and I will explain about the rheumatic fever definition. So, rheumatic fever is one of a kind non-contagious inflammatory disease possibly developed when improper treatment is given of sore throat or scarlet fever caused by infection with group A streptococcus. Rheumatic fever is caused due to the autoimmune system responding to the strep throat or scarlet fever infection, causing generalized inflammatory response. Cardiac involvement during rheumatic fever can result in rheumatic heart disease that could lead to heart failure and premature mortality.
Hello, my name is Putri Indria and my last 3 number is 200, and now I'm going to talk about the epidemiology of rheumatic fever. So in a research done in 100 countries, the data shows that the average number of rheumatic fever cases is from 50 out of 100,000 cases. However, in a hyperendemic area such as New Zealand and Australia, the cases ranging from 300 to 500 out of 100,000 cases. This is why rheumatic fever is still a problem in a lot of countries. That's all I can say. Thank you.
Hello, my name is Rujan Kosasi with last 3 digits number 021. So I'm going to explain about the risk factor of rheumatic fever. Acute rheumatic fever is an autoimmune disease caused by group A streptococcus infection, and the risk factor for acute rheumatic fever include age, genetic susceptibility, and environmental factors. In general, acute rheumatic fever often occurs in children aged 5 to 14 years old. And in genetic polymorphisms like HLA also have been significantly associated with rheumatic fever. In addition, risk factors of acute rheumatic fever are usually influenced by social and economic factors, and based on studies that have been conducted, the case of acute rheumatic fever is strongly influenced by community income and demographics. Acute rheumatic fever is also influenced by environmental factors such as contact with the environment, exposed to gas, household crowds, humid and cold environmental conditions, and exposure to insects. Health factors such as the availability or absence of health services, public health conditions, and nutrition also have a major influence on the prevalence of acute rheumatic fever. Thank you.
Hello, my name is Shantika Aprilia Rahmawati with my student number 106. Here I'm going to explain the pathogenesis of rheumatic fever. Rheumatic fever develops in children and adolescents following pharyngitis by the infection of Streptococcus pyogenes. Following the infection, there's an activation of innate immune system which introduces the S pyogenes antigens to the T and B cells that has gas and proteins. Then antibodies directed against it in streptococci cross-react with glycoproteins antigens to produce an autoimmune response through a phenomenon called molecular mimicry. The cross-reaction is caused by the similarity structure of S. pyogenes bacterium and the human proteins, which leads to cross-activation of antibodies, and at the same time the human proteins are attacked by the T cells. After that, the organisms attach to the epithelial cells and produce an enzymes allowing them to damage and invade human tissues. It elaborates the cytolysis toxins streptolysins S and O. Of this, streptolysins O induce persistently high antibody titers that provide a useful marker of group A streptococcal infection and its non-suppurative complications. After an incubation period of 2 until 4 days, the invading organisms elicit an acute inflammatory response with 3 until 5 days of sore throat, fever, malaise, headache, and an elevated leukocyte count. Thank you.
Hello, my name is Dara Cynthia Augustine with my student number 069, and I will give explanation about the diagnostic features of rheumatic fever. So, in general, the common major manifestation during the first episode of rheumatic fever are carditis and arthritis. These symptoms will be followed by chorea, which has been shown to have female predominance. Another major manifestation of rheumatic fever are subcutaneous nodules and erythema marginatum, which remain much less frequent but highly specific manifestation of rheumatic fever. Despite this general consistency for each of the classical major manifestation, recent data have suggested the possibility of substantial variability of manifestation in specific circumstances and population. For example, in very high-risk populations such as the indigenous Australia population, there are several variable manifestations like aseptic monoarthritis, polyarthralgia, and low-grade fever. However, the applicability of this variable clinical manifestation in low-risk population has not been tested and is not recommended. And for the further explanation will be continued by my friend. Thank you.
Hello, my name is Nanda Pramsis Cahyani with student number 167. Now, I will continue from the direct explanation about the diagnostic feature in rheumatic fever. The most specific and reliable laboratory evidence to examine the cause of rheumatic fever, namely an increase in the titer body of streptococcal antibodies. This increase generally occurs in the early phase of rheumatic fever. Serological evidence with the anti-streptolysin O test or ESO is the best standard of testing for these antibodies. Laboratory tests that are also commonly used are the erythrocyte sedimentation rate and C-reactive protein. And also, in monitoring heart palpitation during rheumatic fever, electrocardiography is the main examination used to confirm, diagnose, and monitor the subclinical state of the heart, aortic, and myocardial patient, because auscultation in physical examination cannot confirm the presence of the lesion. Thank you.
Hello, my name is Zaki Arafi Aidi with student number 122, and Today I will tell you about the differential diagnosis of rheumatic fever. There are several diseases that have the same symptom as rheumatic fever, such as systemic lupus erythematosus, and then gout pseudogout, and then infective endocarditis, septic arthritis, and also Lyme disease, and also leukemia. Systemic lupus erythematosus has unique symptoms such as malar butterfly rash, joint pain that usually affect hand and wrist. Gout and pseudogout can also be mistaken as rheumatic fever, but gout and pseudogout will begin its manifestation in metacarpophalangeal joint with an excruciating pain followed by flaky skin over affected joint. Infective endocarditis also have similar symptoms with rheumatic fever. The difference is that infective endocarditis usually manifests into sepsis, and there will be a sign of organism in the blood culture. Septic arthritis, in which patient will only experience pain in one joint and patient will look toxic or pale and lethargic. And then there is Lyme disease. Lyme disease is characterized by a circular expanding rash with central clearing erythema migraines. In the later stage, Lyme disease can cause influenza-like symptoms, acute neurological problem, and arthritis that can affect knee and heart. And then the last, leukemia. Usually, patients with leukemia have a history of lethargy, weight loss, night sweat, and bone pain. And sometimes patients with leukemia also suffer from bruising and spontaneous bleeding. Thank you. That's all I can say.
Good afternoon, doctor and friends. My name is Udayana and my student number is 123. So I'm going to explain about the treatment of rheumatic fever. So there are two strategies for eliminating this. The first is for eliminating pathogen use. First is the penicillin drug, that is consists of phenoxymethylpenicillin that with children more than 27 kilogram weight is 500 milligram 2 or 3 times a day for 10 days, and with body weight less than 27 kilograms, so given 250 milligrams 2 or 3 times a day for 10 days. The The second is benzylpenicillin. Benzylpenicillin can be given as an alternative, but used only in the hospital facilities because it is given intramuscularly. For the dose, patients with a body weight more than 27 kg give 1.2 million international unit, and with a patient that have a body weight less than 27 kg give 600,000 international unit. And the last is amoxicillin that can be given orally for 10 days at a dose of 50 mg per kilogram, so maximum dose of 3 kg per day. And if the patient has a penicillin drug allergy, you can give clindamycin to 20 mg per kilogram per day, 3 times daily for 10 days. The second is clarithromycin, 15 mg per kilogram per day, 2 times daily for 10 days. And the last is azithromycin, 12 mg per kilogram, 1 times daily for 5 days. And the second treatment that used for treating the clinical manifestation is the first arthritis. We can use NSAID drug. The first aspirin is used for 2 until 3 weeks at a dose of 100 mg per kilogram per day, and once the symptoms completely improve, aspirin should be tempered down for 60 to 70 mg per kilogram per day. And the alternative drug is naproxen at a dose of 10 until 20 mg per kilogram per day, 2 times daily given. And the second clinical manifestation is carditis. That for mild carditis can be given aspirin 100 mg per kilogram per day for 2 until 3 weeks. And for moderate to severe carditis, prednisone 2 mg per kilogram per day, and aspirin 50 until 75 mg per kilogram per day for 12 weeks. And the last is chorea. That for mild chorea, diazepam or phenobarbital are administered. If the condition is not improving, haloperidol 0.225 until 0.5 mg per kilogram per day, or valproic acid 15 mg per kilogram per day when the extrapyramidal symptoms is present.
Hello, my name is Udayana with student number 239. Now I will explain about the prevention and control of rheumatic fever. Prevention of rheumatic fever grouping into two main prevention, that is primary prevention and secondary prevention. Primary prevention of rheumatic fever consists in the proper treatment of streptococcal pharyngitis. The diagnosis and adequate antibiotic treatment of group A staph pharyngitis is the primary means of preventing acute rheumatic fever. For the secondary prevention of rheumatic fever, required antibiotic prophylaxis to reduce the likelihood of required attacks in person with a history of acute rheumatic fever. Because acute rheumatic fever frequently recurs with subsequent group A staph pharyngitis infection, long-term prophylaxis duration should be individually tailored. It usually administered from 5 till 10 years from the last RF relapse or up to 21 years old. This secondary prevention make use of benzathine, penicillin, and phenoxymethylpenicillin. Thank you.
Hello, my name is Pratista and my student number is 227. So now I'm going to explain about the prognosis of rheumatic fever. Rheumatic heart disease is one of the manifestations of rheumatic fever associated with long-term morbidity and mortality reaching 30% to 70% of all cases of rheumatic fever. The development of penicillin can affect the chance for rheumatic fever to evolve into chronic valvular disease. Before being given with penicillin, the percentage of rheumatic fever patients that develop into valvular disease is numbered by 60 to 70%, whereas if being compared with those after being given with penicillin, only 9 to 39% patients evolve into valvular disease.
Hello, my name is Daniel Sungutama Limo, student number 045. For the conclusion, rheumatic fever is one kind of non-contagious inflammatory disease caused by the autoimmune system. The incidence of rheumatic fever varies between country to country. The average was 50 cases out of 100,000 children. Risk factors of rheumatic fever are age, environmental factors, and socioeconomic factors. The diagnostic features of rheumatic fever include carditis, arthritis, chorea, erythema marginatum, polyarthralgia, and low-grade fever. Several differential diagnoses of rheumatic fever are SLE, endocarditis, arthritis, Lyme disease, and leukemia. Antibiotics can be used for the treatment of rheumatic fever. Lastly, there are two kinds of prevention for rheumatic fever. The first one is called primary prevention by getting the proper treatment of streptococcal infection, and the second one is called secondary prevention by using antibiotic prophylaxis. Thank you.
That's all from our presentation. Thank you for your attention, and we close it with Paramasanti. Om Santi Santi Santi.